Very good evening. It's still good to see at least more than 50% of the crowds are still here. Good. All right. Even though it has been a full day for us, all right, we are into the last agenda of the day. There is a panel discussion on the role of laboratory in managing non-communicable diseases. We have invited four esteemed panel. Let us welcome the panelists for this session. There is Professor Dr. Lim Li Ling, an endocrinologist from University Malaya Medical Center. Next, we have Dr. Zakiah Muhammad Said, whom we have heard just now, who is actually a public health physician from the Family Health Development Division, Ministry of Health, Malaysia. Next, we welcome back Dr. Tony Badrick from RCPA QAP. And finally, our fourth panelist, Mr. Harif Muhammad, the CEO of Premier Integrated Laboratories. Okay. Now, we are talking about NCDs, all right? And whether you are aware, whether we want to admit or whether we are seeing it, we are actually battling with NCDs, all right? Where we are, you can see it for yourself, all right? Whether we are doing well or we are not doing well, whether we are going towards a healthy population or not. Now, the thing is about NCDs, all right, it is putting a lot of burden, okay, on the healthcare and also on the economics. It's a lifelong disease for most of it, okay? And according to our latest National Health and Mobility Survey, NHMS 2023, it showed an upward trend in diabetes mellitus from 2011 till 2023. Okay, the overall prevalence of diabetes among adults is 15.6. All right. Now let us start with Professor Lim. Yeah. Based on your years of experience managing diabetes and what you are seeing, okay, how has the laboratory played its role in the diabetes mellitus detection and inpatient care?
Thank you, Dr. Tengku. So, I mean, the lab has been very supportive of this while for diabetes and endocrinology services. Because in terms of diabetes, then we actually depended heavily on the glucose as well as the A1C as the diagnostic criteria for diabetes. Then it's lab-based, and of course, I mean, even previously when an IMR actually did few studies, we even have our own population-specific A1C threshold for the diagnosis of diabetes.
All right, thank you. Now, we move on to Dr. Zakiah, yeah? We have heard your excellent talk on the HPV screening program in Malaysia, and that is also a subject close to your heart. Now, based on, again, on our National Health Mobility Survey for the latest report, and when we look at the health screening, yeah, the findings showed that only 6.8% of occult blood testing was done. I mean, among the population, and Pap smear examination is only 34.9%. Now, is there a role for the laboratory to contribute more or to do more in making these two screening programs achieve a better public acceptance?
Okay, so thank you for the questions, Dr. Tengku. So in fact, I believe that the role of pathology in terms of bringing down the incidence of the main cancer, especially the cervical, the breast cancer, and also the colon cancer is actually really meaningful. And in terms of the role of pathology in bringing down, how we are going to bring down the incidence of cervical and also the main cancer, especially when we are looking at in terms of the enhancing accessibility. because we know that these two cancers, the screening tool, especially for cervical and IFOP, we have the self-sampling technique. So this is actually the main indicators, especially for our population, for our Asian population, especially for Malaysian population, in accepting this approach. Because nowadays, we tend to empower our population by having the self-sampling. So I think that the role of self-sampling is actually very meaningful in terms of improving the awareness, improving the acceptance, and hopefully improving the detections of the cancer, especially on the earlier part. Apart from that, I think that the modalities that we have, the equipments, we have a so-called mobile equipments. So this is another what we call milestone that we aim to reach the one that are unreached. So this is actually important tools and important strategies to reach to those who are not reached, especially to those in the remote areas. So I think that the role of pathology in terms of improving the access, improving the uptake of the screening is actually very, very much really needed in this the world of cancer screening program in Malaysia.
Okay, thank you, Dr. Zakia. So we have heard the views from a clinician attending a patient, basically under the hospital care, and we also heard the view of a public health physician. Now, let us see the view from the laboratory side, okay? We start with Dr. Tony Bedrick. We would like to hear what are basically the practices in Australia on how the laboratory goes arm in arm with the clinical service in contributing to screening, diagnosis, and treatment of NCDs.
Thank you for the question. I think what we do in Australia is probably what most developed countries do. We use, in terms of NCDs, they often have, in terms of diagnosis, there's two components really, the diagnosis and the monitoring of those diseases. With diagnosis, you really need a sharp cutoff. I'm going to really say what I was just talked about half an hour ago. You need a really sharp cutoff, and for monitoring, you really need good precision, but also good consistency in results between laboratories. So we do what everybody else does, but I don't actually think it's good enough. As I've said, I think there are methodological differences between different instruments and different test kits, and that can have an impact if you've got a tight cutoff or if you're trying to monitor differences in a patient over time, and that patient might go to different laboratories. So I think laboratories should do more. The other thing that came up today was point of care, and we're seeing diagnosis and monitoring by using point of care devices in GPs. That doesn't happen very often in Australia right now, because the rebate that a GP gets for doing a point of care test isn't worth their while to do that test. But the government, I think, are about to release extra funding so that more point of care can be done in the GP world. Because I think, certainly in Australia, something like 80% of patients with type 2 diabetes who go to an appointment at a GP, an ongoing appointment, haven't had a blood test done. For all sorts of reasons, it may be language, it may be accessibility to blood testing, it may just be forgetfulness. They don't get a test done. So when they turn up to have their review, it's a waste of an appointment. It would be far more efficient if there was, providing you're talking about HbA1c and not something that requires fasting, it would be far more efficient if they could do the test on site, and the government see that. So there's going to be more point of care testing in the future, but we still have this issue, as you do here, that doctors don't trust the results. So they'll test both point of care and phlebotomy. That's expensive for the health system. So Australia is doing what everybody else is doing in terms of lab testing, and I guess it's adequate, but it's not as good as it should be, and it costs money, and it wastes time and effort for patients and for healthcare professionals, because we're not consistent enough with our results and we haven't been used in Australia, we haven't been using point of care as effectively as we should.
All right, thank you. Now we'll come back to Malaysia, okay? We have gone to Australia, we are coming back to Malaysia. And now, Mr. Harif, you've been a lab technical personnel. You've crossed over to the diagnostic company. Then you came back, all right, to manage a chain of private laboratories.
You just revealed my age.
Right? Now, based on your experience, all right, how do you think the laboratories in Malaysia have evolved over the years with regards to its scopes of service in relation to its role in NCD detection and patient care?
Thank you, Dr. Tengku. First, I believe we have come a long way. And I don't like saying this, but COVID actually brought the lab up from the basement. Sorry, as UKM lab, you are still in the basement. Up to the public view. So we have come a long way, and with technology, we have also come a long way. Tony mentioned about point of care testing. It was there, and then at one time, the doctors are unsure about the quality of point of care testing. Now, I believe there is a role of point of care testing in NCDs because there are improvements in the technology, in the science of it. And I always believe lab have three roles. Number one is to create the awareness. I'm curious and I'm interested to hear more from the previous speaker just now when someone asked him about why the NCD program is not successful, and he mentioned about we detect too late. Yeah. For example, for diabetes, why are we having 16% of our adult population having diabetes, 1 in 5? Perhaps then I would like to go back to our endocrinologists. Maybe the lab can play a role here in creating awareness among the public community by having, I don't know, what we call pre-diabetes range. That means patients, before they have diabetes, they are actually being told or being aware that, hey, if I did not monitor my glucose properly, I will fall into that trap and I become diabetes. I remember in my organization, we have this program, what we call U-turn pre-diabetic, 5 years ago, where we try to screen our employee and we try to identify those people who are in the pre-diabetic range, and we advise them for modification and something that hopefully that they can go back and become normal. So that's my long answer. And again, lab, their main role now is, when it comes to NCD, is to help in early detection. So creating awareness is one. Then we come to accessibility, like what HPV program has done. We created the accessibility for the community to do HPV screening, and we come up with a novel method of self-sampling. Not many people know about self-sampling, Dr. Zakia, again. In fact, I was surprised also when it was first introduced. What is this self-sampling? So that has already created that avenue for people to want to do more HPV screening. And the third role is affordability. By creating accessibility and awareness, and by volume, we will be able to press down the price of screening and make it more affordable. So I believe that is the three main roles of a lab, what I call the AAA.
All right. Okay. Thank you, Mr. Harif. Now, we'll go back to Prof. Lim. All right. I mean, NCDs is really like, I wouldn't want to say a losing battle because it sounds so demoralizing, but yes, you know. So we are a sweet population. At the same time, we are also a bulging population, all right? Because again, our latest National Health and Morbidity Survey also showed that the prevalence of overweight, obesity, and abdominal obesity increased almost 10% from 2011 to 2023. The current prevalence of overweight and obesity is 54.4%. All right?
I think you should have to stop picking on me. Eh? First age now.
All right. So we are sweet, bulging, and aging. All right. Okay. Don't worry. We are not far off, Harif, you and me. Okay. Now, problem. You know, if you can have your magic wand, you know, and tell the lab, and the lab will follow to every request that you have, you know, what can we do? What can the lab do to enhance its role in combating NCDs, you know, especially now in the era of genomic medicine? You know, we are talking about detection even now at birth, you know, whether you're having that precursor gene, you know, of course, and people are now doing such testing routinely, looking into cancer gene and all that. You know, so if you have your magic wand, you know, and tell, look, lab, you know, and lab has a bottomless pit, no problem with human resource, with money, with everything, technology, you know. What would your wish be, you know, for the lab to do to enhance its role in combating NCDs?
Okay, thank you. And great questions, and then also a great response from previous panelists about what's the role of lab and what would be the current knowledge gap or even implementation gaps in maximizing the impact of preventing NCDs. Perhaps I'll evolve around 4 responses. First, it will be awareness. Second is actually the gaps that we've seen in screening and detection. And third will actually be gaps that we've seen in treatment and monitoring. And fourth will be surveillance, in which we'll touch upon the precision medicine. So NHMS has correctly, rightfully highlighted this heartening statistics about diabetes and obesity, that in order to enhance screening and detection, the public awareness will need to be there. Even though we have lab services, but if the public don't go to lab, we need them to be empowered, knowing that they are actually at-risk population. And this comes to the who are at risk. So one of the group will be those who have intergenerational diabetes, meaning there's been history of gestational diabetes, perhaps women of reproductive age, they do have overweight, obesity, and we need to really let the public know, saying that the offspring of this group of women, they're actually at risk of developing younger onset of diabetes and younger onset of obesity. And this takes years to develop because it's about health literacy, it's about public awareness and education. The other groups of people commonly has been implemented would be if you have the siblings of NCDs, you have hypertension, you have high cholesterol, if your BMI is actually high, or even you have family history of diabetes among the first-degree relative, then you should get yourself screened. And from the endocrinologist perspective, we have actually lowered the age of screening. Previously, it's 40 years and above with either of this risk factor, then they should get themselves screened. But we know that there's actually increasing incidence of younger onset of diabetes and obesity, and we lowered it to 35 years old. Any one of us has gotten yourself screened? No, you're younger than 35 then. Okay. Okay, just talking about this, because it takes years to implement, because it is about education awareness. The second thing about screening detection would be easier to tackle. It's sort of like the low-hanging fruit. We have good lab support. We touch upon POCT, point of care testing. affordability, accessibility, as well as the appropriate distribution according to geographic locations. Like for urban area, maybe the POCT may not be so important because they have ready access to lab. I mean, the actual lab base. But if you're looking into people, at-risk people who live at suburban or rural region, then they actually need point of care. They may not have a sufficient socioeconomic status to keep repeating their clinic visits to any of the GPs or hospitals. So one visit needs to settle everything. And this comes with the importance of point of care testing. Third issue to talk upon is actually the gaps in treatment and monitoring. Tony has rightfully said 80% of people with type 2 diabetes in Australia, they don't come with readily available laboratory results. And this, for diabetes management, we need to make decisions together with the patients. The best would be patients and families, because it's a family disease. It's not a single person disease. If without lab tests on the spot, we can't do adjustment to treatment. We won't be able to know whether he or she has really developed chronic kidney disease. And this actually severely impact the choice of the glucose ring therapy that we could offer. Fourth thing is about surveillance. If we do not have longitudinal surveillance, which is pretty limited in middle-income countries, because we do not have long enough data to predict who will be at risk of developing heart disease, who would be at risk of developing diabetes, young onset diabetes, who would be at risk of developing kidney disease. And this will actually tell us, saying that clinicians with lab, because some of your people actually come back to your lab regularly, like private labs. We have those who have been having packages for 5 years, 10 years, so you have the longitudinal data. This comes to a collaborative approach between government, academia, and it's a public-private partnership. And it's time to have a data linkage. Then you'll be able to save some resources of creating this longitudinal data set, will help us to predict who, have a more detailed, deep phenotyping of our population. And this will come into precision medicine.
Yep. Yes, thank you, Prof. Lim. Actually, we are talking about the connectivity, the network that will follow the patient, and regardless where the patient appears, that history, the so-called NCD risk, will follow or can be seen or detected or realized by the next attending physician, and because it's an opportunity to catch that patient the next time he or she appear at whether it's at health clinics or a GP. So that is something, yes, actually that is our wish list for a very, very long time, to have that kind of interconnectivity. Thank you, Prof. Lim. So Dr. Zakia, we've heard a lot about awareness, education, screening, all right? And we know very well that, when you're talking about NCDs, it is actually to catch them early, not when they have full-blown disease. And here, primary healthcare is very important, all right? To either prevent, to put in the preventive measures in terms of the education, and also to catch them early. Now, should the laboratory increase its effort and resources, for NCD screening and early detection, as opposed to more focus on patient care, basically either under the medical patient care as opposed to the primary disease prevention? What's your say on that?
So thank you again, Dr. Tengku, for the question. So I think that in terms of the resource allocations and also distributions, yes, this is actually a long time discussions in Malaysia. I think the proportion of the budgetary, the proportion of the funding is unequal. So unequal in terms of the proportions of the prevention and screening and also patient care. So these are all the effort that has been lobbied by all the preventive practitioners and also the primary healthcare practitioners to improve these distributions. Okay, for instance, we know that based on the evidence, by having a lot of investment, by putting a lot of investment in the prevention, the primary care for the early screening, for the early detection and screening, it can save you a lot. So I do believe that the policy and the vision towards that remain, and we need actually to strengthen and improve the strategy. So via maybe quite a heavy political will that we need actually to gather. So in line with that, I think that the way forward is by having this the healthcare reform. So the white paper, I think this is actually the way forward to transform the initiative, to transform the whole healthcare system towards a good outcome for the population in Malaysia. And I think that in the health white paper, it have 4 pillars. Basically, the 2 first pillars is actually talking about the prevention and also early detection of the diseases. So if, let's say, this white paper become a realistic for Malaysia, I think that this is actually a good move for Malaysian towards a better awareness, better prevention, and a better intervention for the NCD problems as a whole. And number 2, to support the early diagnosis and also early interventions, we need actually to have an adequate funding, especially for the laboratories, because we know that in terms of the NCD, this is actually not only prevalent in Malaysia, but all over the world. So there is a study quote that by having the increment of 10% of the mortality due to NCDs, it will reduce the productivity of the countries by 0.5%. So that's much of NCD contribute to the productivity of the country. And number 3, when we are talking about NCD as a whole, I think that all of our panelists have touched. So we are talking about the screening, the early disease, early detection, a good intervention, and also for further management and treatments. So in terms of the resource allocations for laboratories, it's very important, especially when we are going to get an accurate result, reliable data for the very effective intervention later on. So I do believe that the resource allocations need to be improved, need to be distributed equally, especially on the second part, especially on the diagnosis part, and also the follow-up. Because when we are talking about NCD, it's not only talking about screening, but later the follow-up, the surveillance. So this follow-up data, this follow-up reports, especially from the lab report, will determine what is the best for the individual in terms of the treatment, in terms of the later management and everything. So indirectly, it will maybe cause reductions of the morbidity and mortality of the country. So in summary, I do believe that by putting the equity in terms of the resource allocation, it will making a NCD effort towards NCD reduction effort in Malaysia become more stronger and stronger.
Okay, thank you, Dr. Zakia. Yes, we are looking forward to the healthcare reform and the healthcare white paper as well. All right, Dr. Tony Bedrick, we heard a lot of POCTs. We heard a lot of self-testing now. I mean, we are talking about patient empowerment as well into taking care of their health, doing things better, self-testing, POCTs. Now, how do you envision the laboratory's role and existence, all right, when let's say we are talking about lots of self-testings, we are talking about POCTs being more and more introduced and more good kits are being made available now. Okay, how do you see 20 years from now, 30 years from now, the laboratory's role and existence, all right, when more and more of this is in place and more AI is being used or being incorporated in the laboratory processes, including reporting, are we in 20 years or 30 years, will be more like a pathology kiosk, like you go and put down your fingers, biosensor kind of thing, and a report will come out, that kind of thing. So I mean, I'm asking you to look into the crystal ball, basically. Would there be a change in practices?
I think there has to be. I think there are a couple of things. I think the comment made by the health economist is very relevant. We're measuring the wrong things. We need to measure things that are better predictors of disease, and perhaps they're genetic. At this stage, you know, we can understand not much about what's going on in our genes. You know, we can identify the easy genetic abnormalities. We can't understand, or we can't identify the more complex ones. So I think, and this is really crystal ball gazing, I think we need to, when we're born and we have our whole genome sequence, we need to be identified then what we're at risk for. So I think the problem currently is the markers that we use are too insensitive. They develop after the disease has already progressed. So we need better markers. The next thing we need to do is we need to provide, once you've been told that you're at risk, we need to give you some way of constantly monitoring that risk changing. With weight, you know, you think it'd be a scale, but with some of these other markers, perhaps they need to be the things that we're doing our self-testing on. When we're told that we might have an increased incidence or likelihood of developing thalassemia, perhaps we need to do some self-testing at home with something that will tell us that. The problem, though, we've also got as humans is that, as I said, with quality control, we're not actually very good at making these sort of decisions. We're not very good at following through when we see that there's a problem. So I think it needs to be, you said AI, I think it does need to be automated. I think we need a little thing on us that tells us, oh, it's time not to eat. It's time to get up. And I think we need somehow to have that enforced. So I think from the time that we're very young, from the time we first go to kindergarten or preschool, we need to be told how important it is that when the watch says do something or don't do it, we take notice. So I think we need better markers. We need to be identified who's at risk at a very early stage in life. It's not going to be people in this room, I hate to tell you, and then we need to be educated almost from birth that we have to do something, otherwise we're going to get ill. Maybe this will mean we'll live till 130, or maybe Big Brother will take over and we'll all end up in jail or something. I don't know, but I really think one of the problems is markers, wrong markers. We don't have the right markers. We don't have the right psyche to look after ourselves. You know, look at the people who gamble and who smoke and who drink. No matter what happens, we need help. We need AI. We need something, but education as well.
All right. I hope some of us will live long enough to go through that future. All right. I'm sure technology is evolving, and I think more importantly, we have to embrace the technology and change. And I think we have to realize where our role is as the technology moves. We cannot be static or remain where we are and doing things exactly the same. Now,
can
Mr.
I
Harif.
add on
Yes.
something?
Yes.
So since we touch upon genetic medicine, just putting aside saying that it's costly and anything, and we do have appropriate lab resources for whole genome sequencing or whole exome sequencing. So unlike cancer, which tend to be monogenic, diabetes and obesity actually tend to be polygenic disease. And of course, data from other ethnic ethnicities, we can build population risk score, etc., to predict. This once we have made it cheap, affordable, and accessible, you are able to identify people who are at risk of developing diabetes and obesity. It's sort of like you're doing early screening to detect pre-diabetes, then you give health promotion activities. So similarly, if you offer that, you give health promotion activities. So this is sort of like a preventive medicine. So what lab can help us is offer cheap whole genome sequencing and whole exome. And
Yeah.
we also need bioinformatics experts to help us to analyze it and come to the end users.
He's
Over
talking to you, Harif. Okay. Yes, yes.
I agree with you 100% on that part. Yeah, I believe that, yes, genetic testing is the way forward for pathology, and bioinformaticians will be the new lab personnel that will be seeing more and more coming into pathology, whether we like it or not. And IT, we talk about digitalization of information, yeah? Just now someone mentioned about the need for us to have longitudinal study. It was you. So digitizing our data is also very important. That's why we need lab information system that can be connected to all
Integrated.
integrated diagnostic services. Yeah,
Yep.
these are the future that I
Yep.
believe. Sorry.
Yep. So yeah, I mean for those who are the what we say pelapis kami sekarang lah, the younger generations, you are going through this because now we are developing all these algorithms.
Yeah.
You know, what we learned many years ago will not be in practice in years to come. So you all will be seeing this, you know, because we are doing the algorithms now. We are doing things. We are detecting. We are using AI-assisted reporting, and soon, you know. But of course, it takes the human to do it. But don't worry, you know, we will not be out of job. But it's just that how we do things will be a bit different, and that is where we need to change in the progress of technology, and we cannot remain static because then we will remain, and then we will be obsolete. Okay. Now, Ms. Arif, if you can have your wish, you know, how do you want the laboratory and the clinical interface to be? How can it be improved for us to enhance our effort to combat NCDs?
This is actually my favorite subject. It's the C word. Communicate, communicate, communicate. And I have always been advocating collaborative medicine. So where, you know, we in the pathology, we like to be in the basement, always in among ourselves, looking at our specimens, you know. So I think it's about time that the pathology fraternity have to be involved. Get yourself involved in the policy making of NCDs and to improve our communication channel. I think that is where, for example, in some of infrastructures, we must have our data to be digitized, because once we have that, then it is easier for the other side to be able to extract. Big data analysis is very important. One example I was just looking at recently, for example, the Malaysian Society of Nephrology, together with MACB, they embarked onto this project where they have this kidney disease risk ratio, right? To be put
incorporated in the results.
into the results of your lab. So this is democratizing the risk assessment easily. So all GPs, whenever they run urine serum creatinine and urine microalbumin, they will have that kidney disease risk score, and then immediately the doctors will be aware that, hey, this patient, if they didn't do anything, they will regress to have kidney failure. So these are very simple things. The other one is the FIB4 score for fatty liver, right? Again, this is a cheap, easy algorithm that you should incorporate in your report so that you, in a way, create awareness to the doctors that, hey, if these people are in that risk category, they will be at risk of getting fatty liver. And if you do it now, you are able to reverse them from getting that. Similarly to pre-diabetes.
Can I have one more wish list?
Yes.
Can you incorporate routine urine albumin creatinine ratio into your health screening package?
Have we done that already? We can do that.
With a cheaper rate?
I didn't say anything about price, but your wish can be. So again, this is the dialogue. The communication must be there between the clinicians and the lab. Co-research is another area. Co-research, that means when the clinicians do research, they must include people from the pathology side, and you must acknowledge and recognize their contribution. So basically, it's the C word: collaborative, collaborate, communicate, and that is the only way for us to improve our healthcare service delivery.
So, basically, for us here, mainly involved, all of us here, actually majority of us here involved in provision of pathology service. We have to move away from our traditional role, all right? We must move away from our traditional role, being behind the scene. We must play our role, make our existence felt and contribute because we are part of, we do not take care of patient directly, but we do have that role, all right? As you all have heard from our expert panelists, you have heard their views, you have heard their wish, all right, on how the lab can do more, all right, whether it's costly, and some of it is not costly at all, but it just takes a bit of effort. But what is all this for? And we have heard from morning till evening, it's all about patient care. Finally, it's not about the numbers, it's not just about the test, it's just not about the IQC, it's not about the EQA. It's not doing that. It's basically what we are doing finally translate to patient care and patient safety. So I think we should realize our role, our enhanced role now. I think we should be informed, we should keep up progress of time, and we should also, again, from time to time, talk to your colleagues, clinical colleagues, and see, what is their needs, all right? I can't see if there's any question here because the screen has been locked, all right? Did anyone type in any question? Too tired dah.
Perhaps can I raise one wish list, one more? Sorry.
Oh, yes.
Yeah, since all the...
Today you have all the green light to say out your wish. And they are here to hear it, especially him.
Yeah, thank you. So, I mean, one of the things that we were talking about is the use of point-of-care testing. We do expect it to increase. And sort of like clinicians and end users, we are not too familiar about the point-of-care. Just now Tony was saying that clinicians when unsure about the reliability and accuracy of point-of-care testing. But since we have QAP here, quality assurance, perhaps we can educate clinicians about how quality assurance comes about with regards to point-of-care testing. Yeah.
All right.
I think somebody asked about QC and EQA with point of care. QC is all about the cartridge, EQA is all about the operator. So what EQA should be doing with point of care is identifying problems with the operator. The material that we use for EQA point of care isn't ideal because really the material you need is capillary blood. So that's a problem, it's unstable. But really what EQA for point of care devices is all about the operator. Most point of care devices are bulletproof. Sure, they've got limitations, but it's not in their analytical capability. It's the way people use them or don't use them properly. That's the issue. So, but really, given time and appropriate education, anybody can use a point of care device. Just whether or not that optimally is done by a clinician or somebody in their staff, I mean, that's an issue about using the workforce most appropriately. But point of care devices are becoming simpler and simpler to use. They're very reliable. The only thing that can go wrong is that somebody uses an out-of-date cartridge or they forget to copy the result down because it's not connected or there's an issue with calibration, something like that. The problem is always the operator, it's not the device. So it's all about education.
All right.
I also believe the MOH is doing a point of care testing policy.
We already
guideline.
have it. We already have our guideline, our own POCT guideline. It's rather comprehensive, actually. We are running short of time, but I will just go through some of it. There's some of the question. Does the government is obliged to screen its public servant for NCDs? Actually, this is where our screening program comes in. Our COSPAN. Screening, actually. It is actually try to screen for NCDs, whether it's by questionnaire or going to get your self-check at the staff clinic, right, Dr. Zakia? And then there's one more question. Does the panelists think about work-related NCDs? What does the panelists think about work stress in relation to NCDs? So are we looking into this in terms of primary care?
Again, I'm not so clear about questions.
Work stress related NCDs.
Or work stress related with NCD. So as a policy, there's no, not yet, in terms of the policy direction to see the elements of the work stress and in relation with NCD. However, there are a lot of research on that component. So we just emphasize on the improving of the awareness and the screening update for the NCDs.
I think, Dr. Nazam, I think we are going to approach you to get our research done on work stress related and NCDs, right? I think we'll keep in touch on that. The next question is not a question, but I think this is directed to you, Cik Harif. NCD screening is good move. However, lab test costs self-pay easily 100 ringgits in simple general tests. How can lab lower the price and to be made affordable? You shall think about it, all right? Okay. All right. We are running short of time. All right. I think it has been great to have all the panelists here. I think we have heard their views. They have given their views, their thoughts. All right. It has been a good discussion as well. And there's a good take-home message for us from this panel discussion. Because fighting NCDs is everybody's responsibility. I think we should strive and work together, whether we are laboratory, we are clinical, we are in public health. I think we should strive to work together more effectively, more efficiently, using current technology to together combat NCD for a healthier population. Before we end, I think I, on behalf of panelists, would like to thank RCPA QAP for this invitation for us to be part of this celebration of your 35 years anniversary. Thank you to all the panelists. You've been great, and thank you to all of you.